Hello friends. A patient with nipple discharge is a very common scenario in the breast OPD. Literature says that 6 to 10% of patients attending the breast OPD complain of nipple discharge. But before we understand how to approach a patient with nipple discharge, let us in short revise the anatomy of the breast. The functional unit of a breast is terminal duct lobular unit. There are 15 to 20 such systems or segments in each breast. On an average, 5 to 9 milk pores are which each corresponding to a central duct open into the nipple, and the other orifices that are seen at the nipple are the blind sebaceous glands. Within each duct, 1 to 2 cm beneath the surface of the nipple is present the lactiferous sinus. Recent studies have also noted that these ducts have tiny sphincters. The lobules as well as the ducts secrete fluid under normal circumstances. The nipple secretion is usually not appreciated clinically in a non-lactating woman because the tiny duct is obstructed by a keratotic debris. However, this secretion can be obtained by nipple aspirator device or lavage. When these secretions become copious and extrude spontaneously from the nipple, it is called as nipple discharge and it becomes a point of concern. Breast cancer is believed to be a result of progressive and morphological changes in the duct lining the epithelium, the duct. These changes have been extensively studied in the last 2 decades. It is very important to predict or prevent the breast cancer, if not to at least detect and treat it in early stages. This is the multi-step pathogenesis of the breast cancer. A physiological nipple discharge usually involves both the breast, involves multiple ducts, is non-spontaneous, scanty in amount, can be clear or milky, and a mass is usually not palpable. This video shows a patient with physiological milky discharge from the breast including multiple ducts. A nipple discharge is pathological when it is unilateral, when it is single or spontaneous, and serous or blood stain. It may or may not be associated with a palpable mass, and it is usually copious. This video shows a patient with duct ectasia with copious serous nipple discharge from a single duct with an associated mass. The cause of nipple discharge can be assessed roughly based on the color. Duct ectasia usually has a clear nipple discharge. A milky discharge can be seen in patients who are breastfeeding or hormone-related causes like prolactinoma or in galactorrhea. A yellowish color discharge may indicate infection. Fibrocystic disease usually give rise to greenish discharge or a brown color discharge. However, if there is blood, you should suspect an intraductal papilloma or even malignancy. It has to be remembered that more than 90% of serous discharge are benign and more than 80% of blood stain discharge are also benign. But as a surgeon, we cannot afford to miss the 10 to 20% of cases which can have an underlying malignancy. Hence, any patient with nipple discharge should be thoroughly worked up. Triple assessment is the baseline of any breast patient. A thorough history in terms of age, history of lactation, the characteristic of discharge, any associated pain or lump or any other symptoms should be carefully noted. Medication history should be carefully asked in depth. Sometimes these patients may be on antipsychotics, anti-tubercular drugs or GI drugs or motility drugs. Chronic morbidities like CKD should also be ruled out. After a thorough physical examination, the patient with a pathological nipple discharge should be carefully noted. A patient with pathological nipple discharge may have serous or blood stain discharge associated with a lump and or axillary lymphadenopathy, usually a single and with copious discharge. Imaging is the second mode of assessment for any patient with nipple discharge, and there are wide range of imaging modalities available. However, ultrasound is the first and foremost imaging modality for a patient with nipple. Ultrasound is the basic investigation for a patient with nipple discharge. Ultrasound has a better sensitivity than mammography to detect intraductal lesions. It has a sensitivity of 65% and specificity of 75 to 80%. What is important during performing the ultrasound? The radiologist should start at the 12 o'clock position and then gently turn the probe in the clockwise direction all around the breast. The sonologist should report the location of the area that triggers the nipple discharge on compression. This is an image which shows a thick beaded secretions inside the duct which are not vascularized on color Doppler. The second picture shows a duct which is completely echogenic content with thick secretions. However, in this picture, the duct contains a small intraductal mass which had a central vascular pedicle on color Doppler, which was a small papilloma. Ultrasound can also help to detect dilated tortuous ducts like shown in this picture. Ultrasound can also detect a small mass inside the duct which has a small pedicle on color Doppler and turned out to be a small papilloma. It can also detect a heterogeneous hypoechoic lesion like shown in this picture, or a Birat's 4 lesion in a patient with hemorrhagic nipple discharge from a single duct which turned out to be an infiltrating ductal carcinoma. Mammography is also one of the first-line investigation for a patient with nipple discharge. However, its sensitivity to detect intraductal lesions is only 20 to 25%. Hence, it is mandatory to remember that a negative mammogram does not exclude any underlying disease. However, a mammogram can be used to detect calcifications, masses, focal densities, or asymmetry. A mammogram can detect eggshell calcifications like in a papilloadenoma or rod-shaped calcifications in duct ectasia. Fine pleomorphic microcalcifications can also be detected on mammography, which turned out to be infiltrating ductal carcinoma in this patient. Mammogram can also detect a benign mass like in this case or an irregular mass which was a papillary carcinoma in this case. It can also detect an asymmetry in a patient with duct ectasia which can be further evaluated. A ductography can be used to detect and locate lesions causing intraluminal defect by injecting a dye through the nipple into the duct. It can detect a filling defect which can be involving a single duct or multiple ducts or a stenotic lesion or a wall irregularity. However, it has a very high false negative rate of 20% and a poor sensitivity of 50%. This investigation is very unpleasant and painful for the patient and hence is not widely available all over. MRI is a valuable additional diagnostic tool in setting of a negative conventional imaging like ultrasound or mammogram. It has a sensitivity of 100% and a specificity of 83%. MRI can aid in diagnosis of different causes for pathological nipple discharge, and it may be mandatory in situations where an initial ultrasound and mammograph are negative. Also, in young patients with intraductal echogenicity on ultrasound, an MRI can differentiate between an intraductal mass lesion or an inspissated secretion. In case of asymmetric heterogeneous breast parenchyma, MRI is a useful investigation. A negative MRI in a symptomatic patient may obviate the need for any invasive surgery, and the patient can be reassured and kept in follow-up. This is an example of an MRI in a 74-year-old lady with a single nipple discharge. Her initial mammogram and ultrasound were normal. However, an MRI showed an ill-defined area of intense enhancement in the upper inner quadrant of the left breast. Similarly, a 50-year-old patient with an initial negative mammogram and ultrasound on MRI showed a small lesion which was irregular and enhancing lesion in the upper outer quadrant, and on relook ultrasound it showed a 8 mm hypoechoic lesion which was found to be invasive ductal carcinoma on core biopsy. The next investigation available is ductoscopy. This investigation not only detects the intraductal lesions, but it can also avoid surgical treatment for a predominantly benign lesion like intraductal papilloma or a ductal dilatation. The specificity of ductoscopy to detect an intraductal carcinoma is 92%. This investigation can also be used for accurate localization, ductal lavage, or intraoperative guidance for locating deep-seated lesions. A new investigation which is under study is virtual ductography. A recent paper from China. The virtual ductoscopy is actually a three-dimensional reconstruction of a spiral CT scan. The study presented here is a study of 46 breasts where 5 patients presented with bilateral nipple discharge and the remaining with unilateral nipple discharge. And the median age of the study group was 47 years. This study could identify a polypoidal solitary lesion or even a polypoidal multiple lesions like shown here. In the study, they further compared the diagnostic modality of virtual ductoscopy with the traditional available imaging modalities like ultrasound and galactography. And what they found was the virtual ductoscopy had an impressive sensitivity and specificity rate. When they added an ultrasound along with a virtual ductoscopy, they did not find any major difference in the sensitivity and specificity of this new modality. However, it is in the initial stages and more data needs to be available for making it as a standard modality of investigation. Vacuum-assisted breast biopsy is a minimally invasive method for diagnosis and treatment of patients with intraductal lesions. It is an effective method for treatment of intraductal papilloma and it avoids invasive surgical excision. However, these patients should be on regular follow-up in order to detect any early recurrence or a new onset in case of a multifocal disease. And any suspicious lesion on follow-up should be actively treated if required surgically excised. Now, this is the biopsy needle which is placed under ultrasound guidance under the lesion. After biopsy, a hydromarker or any clip can be placed under ultrasound guidance. So this hydromarker or which can be identified on ultrasound on follow-up, or if you place a radio opaque clip, it can be followed up on a contrast on a mammography in future. The surgical treatment for single duct lesion is microdocectomy. Here, the discharging duct is cannulated with a lacrimal probe. A circumareolar incision is made corresponding to the trigger point and the palpable course of the lacrimal duct probe. The pathological duct is easily dissected out circumferentially, guided by the lacrimal duct probe. And the duct is labeled, is tied and completely excised in toto. When multiple ducts are involved, the Hadfield's or a core excision is required. The discharging duct is cannulated, methylene blue is inserted, a circumareolar incision is taken and the major duct excision is done. The specimen is scored from the nipple carefully. It's labeled and sent for histopan, which was intraductal papilloma in this case. The skin is closed with subcuticular sutures. One interesting rare phenomenon, rusty pipe syndrome, needs a mention. It's a blood-stained nipple discharge during pregnancy. It's rare and prevalence is less than 0.1%. It is usually a bloody nipple discharge in late pregnancy or early lactation. Usually seen bilateral, painless and is self-limiting. It should be evaluated with triple assessment and cytological analysis of the discharge. If all turn out to be negative, the patient can be reassured. Temporary discarding the expressed milk and using of formula milk may be advocated. However, if the infant is tolerating the milk, the breastfeeding should be encouraged. One has to be very careful in keeping pregnancy-associated breast cancer as one of the differential diagnoses of this condition. Another extremely rare condition is a blood-stained nipple discharge in infancy. It is usually seen due to duct ectasia associated with breast hypertrophy. This is a self-limiting condition and managed conservatively. It is usually due to the influence of maternally transferred hormones, predominantly estrogen, and the resultant secondary hyperprolactinemia in the infant. So in conclusion, when a patient of nipple discharge comes to you, a thorough history and clinical examination in the clinic is mandatory. If the discharge is a non-spontaneous, bilateral and involves multiple ducts, it is usually a physiological discharge which can be proven on imaging. However, an endocrine evaluation including prolactin and thyroid function test is mandatory. If it's normal, then the patient should be taught about self-breast examination, should be reassured and followed up every 3 to 6 monthly. However, if the hormonal workup is abnormal, the medical line of management is opted as the requirement. Sometimes, if it is a very distressing discharge, a Hadfield's operation may be considered. However, if the discharge is spontaneous, unilateral and involves single duct, imaging is mandatory. If the imaging is normal and the patient has a benign blood-stained discharge which is discomforting, a microdocectomy can be considered. Abnormal imaging can be further investigated with a ductography or a ductoscopy if it is available. If these are not available, the patient straightaway needs a microdocectomy followed by histopath of the resected duct. If it turns out to be benign, the patient can be followed up every 3 to 6 monthly. But if it comes out to be malignant, then further treatment needs to be considered as per the staging of the disease. Thank you for your patient listening.